So what we'll do now is, if Dr. Supriya is here, but we'll first have the presentation of Dr. Sudhakar Naidu. I believe this is the best free paper from the Andhra Pradesh Ophthalmic Society conference. So Dr. Sudhakar, please.
Good afternoon to all. I am Dr. Sudhakar. I will be presenting a case series of autologous simple limbal epithelial transplantation. And there is no financial disclosures for the content of the talk. And the scope of my talk is etiology and classification of the limbal stem cell deficiency, the difference between SLET versus SLET, and the video explaining the surgical procedure of the SLET and our experience in this procedure. The limbus acts as a proliferative barrier between the conjunctival and corneal epithelium. Any factors that damages the limbal epithelium result in invasion of the conjunctival epithelium onto the cornea, result in conjunctivalization. This conjunctival epithelium is thick and irregular, unstable, and with or without neovascularization and inflammatory cell infiltration, and which results in epithelial defects, and over course of time it will lead to ulceration and scarring. The limbal LSCD can be primary or secondary, diffuse or total, sectoral or partial, or subclinical or overt. The etiology, it can be primary or secondary. Primary LSCD is mainly due to insufficient stromal microenvironment seen in cases like aniridia, congenital erythrokeratodermia, keratitis, or multiple endocrine deficiencies or chronic limbitis. And secondary LSCD is due to external destruction of the limbal stem cells, and the most common cause is chemical injuries, and other causes are Steven-Johnson syndrome, multiple ocular surgeries, contact lens wearers, or prolonged infections. The difference between CLET versus SLET, SLET is a single stage procedure, and it doesn't need any extensive equipment or stem cell laboratory, and patients doesn't need long-term immunosuppressants. And CLET is a two-stage procedure, so it needs extensive equipment and separate stem cell laboratory, and patients will need long-term immunosuppressants. This is the surgical video explaining the SLET, and first the conjunctive liver tissue is taken from the This is the totally 6 cases were included in the study. All had chemical injury with the tuna powder. This is the case one with 26-year-old male with total limbal stem cell deficiency, and the vision improved to 20/40 after 15 months follow-up period from the initial visual acuity of county fingers 4 feet. This is the case 2 with 22-year-old female with partial limbal stem cell deficiency. The vision improved to 20/40 after 1 year follow-up period from the 2200 presenting visual acuity. This is the third case, a 80-year-old male child with total limbal stem cell deficiency. The initial presenting visual acuity was hand movements, and it improved to 20/60 after 11 months follow-up period. And this is a case 4 with a 32-year-old male child with total limbal stem cell deficiency. The vision improved to 20/100 after 11 months follow-up period. This is a case by 25-year-old female with a partial limbal stem cell deficiency. The presenting visual acuity 20/100, and it improved to 20/40 after 10 months follow-up period. This is the case 6, 28-year-old male with a total limbal stem cell deficiency. The visual acuity improved to 2200 from hand movements after 9 months follow-up period. This is our experience in 6 cases. All had chemical injury with tuna powder, and 5 are adults and 1 each child, and 4 cases had total LSCD, and 2 are partial LSCD, and 4 cases were associated with upper lid symplepharon, which was managed with amniotic membrane excision and amniotic membrane transplantation. These are the result of the study. The mean follow-up period was 11.5 months, and visual acuity improved more than 3 lines, and there is a significant anatomical and visual outcomes, and epithelialization was fully in all cases, and 3 cases have clear cornea, and 2 cases had residual scar, and 1 case had residual scar with vascularization who needed further intervention. So, coming to conclusion, SLET is a simple and effective technique in managing unilateral corneal burns, and which can be done. It can be mastered and performed by any comprehensive ophthalmologist with a regular OT setup and without any special instrumentation or laboratory support. So, this is the pre and post-op pictures of all the 6 cases. These are my references. Thank you.
Multiple of your cases had symplepharon. So, what did you do to address the symplepharon, and did you get any recurrence in the post-op of the symplepharon?
We are usually using symplepharon as well. We are excising the symplepharon.
Please talk in the mic.
Excision of the symplepharon and amniotic membrane placement. And post-op also, we are giving antibiotic steroids for longer periods, and also, if needed, oral cyclosporin also we are adding.
Did you see any recurrence after the amniotic membrane grafting for the symplepharon, which you did with the SLET? Was there any recurrence of symplepharon in the post-op?
In our case, there is no recurrences.
Okay. Because usually conjunctival autograft works better as far as symplepharon is concerned as compared to amniotic membrane alone.
Actually, amniotic membrane alone is better, because conjunctival it is already conjunctival autograft we have to taken from the other eye. Other eye you are already taking the 3 to 4 mm of the tissue. You take more tissue. Usually limbal tissue is important, because if you take the more limbal tissue, other eye has the chances of development of the LSCD.
Whenever there is a large symplepharon, it is preferable to put a conjunctival autograft. That's what we have seen in our experience. Thank you.